Welcome back to the Deep Dive, everyone. This is where we take these huge stacks of research, specialized stuff, and really boil it down into something clear, something you could use. Today, we're digging deep into otolaryngology. ENT, as most people know it.
Right. Ear, nose, and throat.
Exactly.
Yeah.
And you often think of it as like just colds, maybe allergies, that sort of thing, maybe an ear infection here and there.
Pretty routine stuff for many.
But the sources we've piled up for today, they show something much deeper, don't they? It seems like these symptoms, ear, nose, throat, it can actually be, well, reflections of really serious, sometimes life-threatening systemic problems.
That's absolutely the core issue. The line between a simple sniffle that goes away on its own and, say, a dangerous tumor or a spreading infection, well, it can be incredibly thin, measured in days, sometimes even hours.
Wow.
So that's our mission today, really. We're going through this comprehensive stack of sources covering the ear, nose, throat, but also touching on related endocrine, even neurologic conditions. And the goal isn't just to list conditions, it's to find those essential differentiators, the key pieces of information.
High-yield nuggets.
Exactly. The diagnostic levers that help you separate the watch and wait from the act now emergencies.
Right.
We want you, listening, to really sharpen that recognition, to spot the clinical features, the red flags, know the right management protocols, because that's what turns these ambiguous symptoms into a clear path forward.
And it sounds like sometimes that path pivots on just one small detail.
It often does. You'll see. Something as simple as how long a fever lasted or exactly where a neck mass is located. It can make all the difference between, say, saline spray and needing an emergency surgical airway.
Okay, let's start right there. At the entrance, the nose and sinuses. Rhinosinusitis. This has to be one of the most common reasons people end up seeing a doctor, right?
Absolutely. It's incredibly common.
But it feels like the whole antibiotic decision. It gets misused a lot. How do we really draw that line, between a regular viral cold and something that actually needs antibiotics, like acute bacterial rhinosinusitis?
Yeah, that's crucial. And the line isn't about what the discharge looks like. That's a big misconception.
Ah, so the green or yellow mucus doesn't automatically mean infection.
Nope. Zero diagnostic value for bacterial infection. Mucus changes color and thickness naturally as your body fights any inflammation, viral included. It's just inflammatory cells doing their job.
Okay, so ditch the color code. What is the line then?
It boils down to time and severity. Viral rhinosinusitis, which is overwhelmingly the most common cause, especially in kids, it gets better on its own, usually within, say, 5 to 10 days.
All right.
So the management is just supportive care, saline rinses, maybe NSAIDs for pain or fever, hydration. Let the body handle it.
Okay, supportive care for most. But when does it become ADRS? When do we pull the trigger on antibiotics?
Right. Acute bacterial rhinosinusitis, or ABRS. The diagnosis is clinical, and you need to meet one of 3 specific criteria.
Okay, what are they?
First, the simplest duration. Symptoms hang around for 10 days or more with absolutely no sign of improvement. Day 11, still feeling lousy. Think bacterial.
10 days, no improvement.Got it. What's number 2?
Number 2 is severe onset. This means things start off really bad. Specifically, a high fever, 39 degrees Celsius or higher, plus that thick, purulent, gunky nasal drainage right from the get-go, lasting for at least 3 days straight.
High fever and nasty discharge for 3 days.
Okay.
And the third one, you mentioned this earlier, the double sickening.
Exactly. The biphasic illness. This is such a key pattern. The patient starts getting better. Maybe they feel, 60% recovered by day 5 or 6.
Oh, they think they're over the hump?
Right. And then, wham, they suddenly get much worse. Fever spikes again. Congestion ramps up. What's happening is that initial viral damage likely weakened the defenses.
Creating an opening.
Precisely. An opening for bacteria, often strep pneumonia or H. influenza, to move in and set up a secondary infection.
That makes so much sense. Okay, so if you see one of those 10 days, no improvement, severe onset, or that biphasic worsening, what's the next step?
Then you pivot to antibiotics, oral antibiotics. Usually amoxicillin is first line, sometimes with a clavulanate added for broader coverage, depending on local resistance and risk factors.
And importantly, what don't we usually need to do?
Right. We generally don't need imaging, like a CT scan, for uncomplicated ABRS. That's reserved for when you suspect complications.
Like the infection spreading outside the sinuses.
Exactly. Things like orbital cellulitis infection getting into the eye socket or signs of intracranial spread. Those are definite red flags needing urgent imaging and often admission. But for straightforward ABRS meeting those criteria, antibiotics are the move.
Okay, that clears up the infection side beautifully. Let's shift gears slightly. Still on the head and neck, But looking at chronic issues, anatomy, inflammation, tortoise palatinus, sounds a bit scary, a bony growth, but it's benign.
Completely benign. Yeah, it sounds ominous, but it's just a harmless bony overgrowth and exostosis right there in the midline of the hard palate, the roof of your mouth.
So how do you know it's just that and not something worse?
Key differentiators are the history and the feel. It's rock hard, completely immobile, doesn't move when you push on it, and it's not tender. And crucially, the patient will almost always tell you, oh yeah, it's been there for ages, since I was a kid maybe. It's long-standing.
And why is that combination, hard, stable, midline, long history, so reassuring?
Because you're immediately contrasting it with the things you do worry about, like malignancy or an active infection, maybe a vascular lesion. Those tend to be softer, maybe fluctuant. They change over weeks or months. They might be painful, ulcerated, or bleed easily.
Got it. So tortoise palatina is just extra bone.
Pretty much. Management is just observation unless it becomes problematic, like interfering with speech or more commonly getting in the way of fitting dentures or retainer, then rarely it might need surgical removal.
Okay. Now, moving to chronic runny noses that aren't allergies, non-allergic rhinitis, or NAR, sometimes called vasomotor rhinitis. How is this different from the hay fever everyone knows?
Yeah, NAR is a common mimic. You get the chronic congestion, the runny nose, postnasal drip, but it's got nothing to do with typical allergens like pollen or dust mites.
So what triggers it then?
It's nonspecific irritants. Things like sudden changes in temperature, breathing in cold air, strong smells like perfume or chemicals, smoke, sometimes even just eating, especially spicy or hot foods.
Interesting. So how do you tell it apart clinically from allergies?
Couple of things. NAR often has an adult onset. Allergy testing like skin tests or blood tests for IgE will be negative.
Yeah.
And importantly, patients with NAR usually don't have the itchy, watery eyes or itchy palate that are so classic for allergic rhinitis.
And the appearance inside the nose.
That's another clue. In allergic rhinitis, the nasal lining, the mucosa, often looks pale, kind of boggy, maybe bluish because of chronic swelling and histamine. In LR, it's typically described as more red and boggy. It reflects more of a nerve-driven vascular reaction, not an IgE-mediated allergic one.
And the treatment?
First line is usually intranasal steroid sprays. Sometimes intranasal antihistamines can help too, even though it's not a true allergy.
Okay, now let's contrast that with something caused by treatment itself. Rhinitis medicamentosa, rebound congestion.
Ah, yes. This is purely iatrogenic caused by medical treatment. Specifically, it's severe rebound nasal congestion from overusing topical decongestant sprays.
Like the over-the-counter ones, oxymetazoline, phenylephrine.
Exactly those. They work great initially because they cause intense vasoconstriction. They shrink the blood vessels in the nose, opening things up beautifully for a few hours.
But the instructions always say don't use for more than 3 to 5 days. Why?
Because if you use them longer than that, the nasal lining gets addicted to the drug, in a way. The prolonged, intense squeezing of the blood vessels actually damages their lining, the endothelium.
Okay.
So when the drug wears off, the body overcompensates with massive, uncontrolled vasodilation, rebound swelling. And it's often worse than the original congestion was.
Vicious cycle. They feel stuffed up, so they spray more.
Making it worse in the long run, exactly.
Yeah.
And the clinical appearance is really distinctive. The nasal turbinates look beefy red and profoundly swollen. It's an angry, inflamed appearance, very different from the pale look of allergies or even the red, boggy look of NAR.
And the cure sounds tough.
It is tough, but straightforward. Immediate, complete withdrawal of the offending nasal spray. Cold turkey. Plus supportive measures like saline rinses, maybe a short course of oral or nasal steroids to help calm the rebound inflammation during the withdrawal period, but they have to stop the spray.
Okay, that's a clear warning. Now, let's up the ante considerably. CSF rhinorrhea.
Yes.
Brain fluid leaking from the nose.
Yeah.
This sounds bad.
It is extremely serious. CSF means cerebrospinal fluid. This leak is usually caused by some kind of trauma that results in a fracture at the base of the skull. Think car accidents, falls, or sometimes it can happen after sinus or neurosurgery.
That's the absolute giveaway sign,
Yeah.
the thing you cannot miss.
The patient usually reports clear, watery drainage, typically just from one nostril. And here's the crucial part. It gets significantly worse when they bend over, lean forward, or strain like having a bowel movement, anything that increases intracranial pressure.
Valsalva maneuver.
Exactly. Gravity and pressure force the fluid out through the defect. They might also notice a weird salty or metallic taste in the back of their throat.
So if someone reports that clear positional drainage, how do you confirm it's actually CSF? and not just, say, really watery mucus or allergy drainage.
You have to test the fluid. You collect a sample of the nasal drainage and send it specifically to test for beta-2 transferrin.
Beta-2 transferrin.
Yeah, it's a protein found almost exclusively in CSF and also in perilymph in the inner ear and aqueous humor in the eye, but not in normal nasal secretions or blood. So if beta-2 transferrin is present in that nasal fluid, it's diagnostic for a CSF leak.
And why is confirming this so critical, so urgent?
Because that leak represents a direct pathway from the germ-filled nasal cavity straight into the sterile space around the brain. The risk of developing bacterial meningitis is incredibly high.
Wow. So this needs immediate specialist attention.
Absolutely. Neurosurgery consultation is usually required. Sometimes small leaks heal on their own with bed rest and avoiding straining, but often surgical repair of the skull-base defect is necessary to close the leak and prevent meningitis.
Okay, moving from the nose to the ear seems like a natural transition, and the stakes definitely stay high here. We need to be able to tell apart common outer ear infections from ones that can, like, eat into bone.
Exactly. Let's start with the common one, acute otitis externa, AOE, better known as swimmer's ear. This is purely an infection of the skin lining the external auditory canal. The absolute hallmark sign, the thing that nails the diagnosis clinically, is pain when you manipulate the outer ear. Pulling on the auricle or pushing on that little cartilage bump in front, the tragus. If that causes significant pain, you're thinking AOE.
And inside the canal.
It'll look red, swollen, maybe some debris or discharge. But critically, if you can get a look, the tympanic membrane, the eardrum itself, looks normal. It's spared because the infection is external to it.
So because it's external, the treatment is local.
Precisely. It's usually caused by bacteria that like moist environments, typically Pseudomonas aeruginosa or sometimes Staph aureus. Water washes away protective earwax, letting them set up shop. So topical antibiotic drops, often containing a fluoroquinolone, sometimes with a steroid to reduce swelling, are the mainstay. Apply them directly into the ear canal.
Oral antibiotics usually aren't needed then.
Generally, no. Not unless the infection is spreading out onto the face or the patient is diabetic or immunocompromised, making you worry about more invasive infection. But for standard AOE, topical drops work great.
Okay, standard swimmer's ear. Now, contrast that with its terrifying cousin, necrotizing otitis externa, NOE, sometimes called malignant otitis externa. That sounds really bad.
It is. It's a true life-threatening emergency. This isn't just a skin infection anymore. This is an aggressive infection, almost always Pseudomonas, that starts in the ear canal but then invades deeper, spreading into the cartilage, the surrounding soft tissues, and even the bone at the base of the skull, causing osteomyelitis.
Who gets this? Is it common?
No, thankfully not common, but it has very specific risk factors. You almost exclusively see NOE in elderly patients with diabetes, or occasionally in other severely immunocompromised individuals. Their poor microvascular circulation allows the infection to just run rampant.
What's the clinical picture? How do you recognize it?
The pain is a key clue. It's usually severe, deep-seated, relentless ear pain, often worse at night, and maybe seeming out of proportion to what you initially see on exam. But the absolute pathognomonic sign, the thing you must look for, is granulation tissue on the floor of the external auditory canal, usually at the junction where bone meets cartilage.
Granulation tissue. So like raw, bumpy tissue.
Exactly. It looks like unhealthy, reddish, fleshy tissue that represents exposed, infected bone. It's not just inflamed skin, it's osteomyelitis surfacing. Seeing that in a diabetic or elderly patient with severe ear pain, that's NOE until proven otherwise.
And the management is drastically different from AOE, I assume.
Night and day. This requires urgent admission and prolonged courses of intravenous IV anti-pseudomonal antibiotics. Often ciprofloxacin is used, sometimes needing combination therapy. Treatment can last for weeks or even months, and surgical debridement might be needed. It's a very serious condition.
Wow, okay. What about chronic ear drainage? Chronic suppurative otitis media, CSOM. You mentioned this involves a hole in the eardrum.
Yes. CSOM is defined by chronic inflammation of the middle ear and mastoid cavity, always associated with a tympanic membrane perforation, leading to persistent or recurrent pus-like drainage, otorrhea, for more than, say, 6 weeks. Often it's foul-smelling.
And you noted that oral antibiotics often don't work well here. Why is that?
It's about penetration. In chronic inflammation, the middle ear mucosa gets thickened, scarred, maybe develops polyps. It's often poorly vascularized. So, antibiotics taken orally, traveling through the bloodstreams, just don't reach high enough concentrations in that chronically diseased middle ear space to be effective against the bacteria hiding there.
So like with AOE, topical is the way to go.
Correct. The treatment of choice for uncomplicated CSUM flares is autotopical fluoroquinolone drops, like afloxacin or ciprofloxacin. They deliver high concentrations of the antibiotic directly through the perforation to the site of infection in the middle ear. Sometimes suction cleaning by an ENT is needed first. Oral antibiotics are usually reserved for complications.
Okay, let's shift focus now to the mechanisms of hearing loss itself. Section 2.2, otosclerosis. You mentioned this causes conductive hearing loss, often in young women. What's actually happening in the ear?
Otosclerosis is a fascinating bone disease. It involves abnormal remodeling of the bone in the otic capsule, the dense bone surrounding the inner ear. Specifically, it often affects the stapes, the last tiny bone in the middle ear chain.
The one that connects to the inner ear.
Exactly. It sits in the oval window. In otosclerosis, this abnormal bone growth essentially fixes the stape's footplate in place so it can't vibrate properly to transmit sound energy into the inner ear fluid.
So sound can't get conducted effectively, hence conductive hearing loss.
Precisely. The classic presentation is gradual, progressive, painless conductive hearing loss, typically starting in young adulthood, maybe the 20s or 30s. It's often bilateral, though maybe asymmetric. And yes, it does seem to affect women more often than men and can sometimes worsen during pregnancy, possibly due to hormonal influences on bone metabolism.
What would you see on exam or testing?
Hearing tests, like the RIN test with a tuning fork, will show bone conduction is better than air conduction, BCAC, which is characteristic of conductive loss. Audiometry confirms this. But the really interesting thing is that otoscopy looking at the eardrum is usually completely normal. The problem is hidden behind it.
Any visual clues at all?
Occasionally, in active disease, you might see something called the Schwartzy sign. It's a faint reddish or pinkish blush seen through the eardrum over the promontory of the middle ear. It represents increased vascularity from the active bony remodeling process, but it's not always present.
And management.
Options include observation, hearing aids to amplify sound overcoming the conductive block, or surgery, a stapedectomy or stapedotomy, where the fixed stapes is partially or fully removed and replaced with a tiny prosthesis to restore sound transmission.
Okay. Now, a different kind of hearing loss, sensorineural, SNHL, and a common congenital cause, cytomegalovirus, CMV. Why is this highlighted, especially for preschoolers?
Congenital CMV infection, meaning the baby acquires it from the mother during pregnancy, is actually one of the leading non-genetic causes of SNHL in children worldwide. It's really important to be aware of.
How does it present? Is it obvious at birth?
That's the tricky part. Some infants with congenital CMV are symptomatic at birth with various issues, but many are asymptomatic. The hearing loss itself can be present at birth, or it can have a delayed onset, appearing later in infancy or early childhood. It can also be progressive, meaning it worsens over time. And it can be unilateral or bilateral.
So a child could pass their newborn hearing screen, but still develop CMV-related hearing loss later.
Absolutely. That's why ongoing vigilance and follow-up hearing screening is important, especially if there are any concerns or other risk factors. If a preschooler presents with unexplained SNHL, particularly if there's no family history, congenital CMV should definitely be considered in the differential diagnosis. Antiviral treatment might be an option if caught early.
Got it. Now, another cause of hearing loss, often conductive and also potentially destructive, cholesteatoma. You described it as a skin cyst in the wrong place.
That's a good way to think about it. It's not cancer, it's a benign growth, but it behaves destructively. It's essentially a sac or cyst lined by squamous epithelium skin cells that gets trapped in the middle ear space or mastoid bone.
How does skin get trapped in the middle ear?
It usually forms because of chronic negative pressure in the middle ear from eustachian tube dysfunction, causing the eardrum, particularly a weakened area called the pars flaccida, to retract inwards, forming a pocket. Skin cells that normally line the ear canal get drawn into this pocket, and they keep shedding keratin debris inside.
And that buildup causes problems.
Big problems. This trapped keratin debris accumulates, The sac expands, and it produces enzymes that are highly inflammatory and can erode bone. It can destroy the delicate middle ear bones, ossicles, leading to conductive hearing loss. It can erode into the inner ear, causing dizziness or SNHL, into the facial nerve canal, causing paralysis, or even upwards into the brain cavity, causing meningitis or abscess.
Wow. So what are the telltale signs?
The necessary clinical differentiators are usually persistent, often foul-smelling ear drainage, otorrhea that doesn't clean up with typical treatments, and progressive conductive hearing loss. On examination, the key finding is seeing that pearly white, cheesy-looking mass behind the eardrum, often within a retraction pocket.
And because it's so destructive, what's the management?
Definitive management is surgical excision. You have to remove the entire sac and all the debris to prevent recurrence and halt the bone erosion. It often requires complex mastoid surgery.
Okay, let's pivot now to 2.3. Vertigo. Dizziness. This can be really disabling. The sources emphasize differentiating based on timing, triggers, and associated symptoms. Let's start with Meniere's disease and its classic triad.
Right. Meniere's disease is thought to be caused by an imbalance of fluid pressure within the inner ear specifically, and excess of endolymphatic fluid called endolymphatic hydrops. The diagnosis rests on recognizing its classic triad of symptoms, which occur in distinct episodes or attacks.
And that triad is?
1. Episodic vertigo. The room spins, usually lasting for minutes to hours, not typically days. 2. Fluctuating low-frequency sensorineural hearing loss. The hearing often gets worse during or after an attack, then might recover somewhat. 3. Tinnitus, ringing or roaring sound, and or sense of oral fullness or pressure in the affected ear.
So all three often come together during an attack.
Typically, yes. The pattern of these episodic attacks involving all three components is key.
And what's the first step in management?
Because it's thought to be related to fluid volume fluctuations, the first-line management is conservative lifestyle modifications. The most important is a strict low-salt diet to try and reduce overall body fluid retention, which might impact inner ear fluid levels. Also, avoiding triggers like caffeine, alcohol, and nicotine is often recommended, as they can affect inner ear circulation or fluid balance.
Okay, so Meniere's is episodic with hearing loss and tinnitus. How does vestibular neuritis differ?
Vestibular neuritis is quite different. It's thought to be an inflammation of the vestibular nerve itself, the nerve carrying balance information from the inner ear to the brain, often triggered by a preceding viral infection.
So how does it present?
It typically presents as a single, acute, severe, and sustained episode of vertigo. We're talking intense dizziness lasting for days, maybe even a week or two, gradually improving. There might be nausea and vomiting. But here's the crucial difference from Meniere's. There is no hearing loss and no tinnitus. Auditory function is completely spared. It affects only the balance portion of the nerve.
It's just intense vertigo, lasting days, no hearing issues. Got it. Next up, paralymphatic fistula, or PLF. This one is triggered by pressure changes.
Exactly. A PLF is an abnormal opening or tear between the fluid-filled inner ear, containing paralymph, and the air-filled middle ear. This leak most often occurs after head trauma, severe straining, like heavy lifting or violent coughing, or barotrauma, like from scuba diving or flying.
And how does that leak manifest?
The leak causes instability in the inner ear. Symptoms, which include episodic vertigo and sometimes sensorineural hearing loss, are characteristically triggered or worsened by activities that change middle ear or intracranial pressure.
Such as?
Things like coughing, sneezing, straining, valsalva, or even exposure to loud noises. That specific phenomenon where loud sounds trigger vertigo is called the Tullio phenomenon. So if a patient says, I get dizzy every time I sneeze hard, or loud sounds make the room spin, you should think about PLF. Diagnosis can be tricky, sometimes requiring exploratory surgery.
Okay. And finally, the vertigo section, the tumor. Vestibular schwannoma, also known as acoustic neureta. What's the big red flag here?
This is a benign tumor arising from the Schwann cells covering the vestibulocochlear nerve, cranial nerve 8, usually the vestibular portion. Because it grows very slowly, the main red flag is usually gradual, progressive, unilateral sensorineural hearing loss. It might be subtle at first. Patients might notice difficulty hearing on the phone with that ear, or just feel one ear isn't as good as the other.
So not necessarily vertigo as the main complaint.
Often not intense vertigo. They might describe more of an imbalance or unsteadiness rather than true spinning vertigo, because the brain has time to compensate for the slowly failing vestibular input. Tinnitus on that side is also very common. The key is that asymmetry one ear clearly worse than the other in hearing or tinnitus.
And as it grows, can it affect other things?
Yes, that's the major concern. It grows in the confined space of the internal auditory canal and the cerebellopontine angle. As it enlarges, it can start to compress adjacent cranial nerves. Most commonly, it might press on the trigeminal nerve, CNV, causing facial numbness or tingling, or the facial nerve, CNZ, leading to subtle facial weakness or twitching.
So asymmetric hearing loss plus maybe facial numbness or weakness?
That combination is highly suspicious. The gold standard test for diagnosis is an MRI of the brain and internal auditory canals with gadolinium contrast. That will clearly show the tumor.
All right, Section 3 takes us into potentially the most immediately dangerous territory: airway emergencies and neck masses. Let's start right at the top with 3.1, acute airway obstruction, focusing on epiglottitis. This used to be mainly a kid thing, right? But not anymore.
Exactly. Historically, epiglottitis was a dreaded pediatric emergency, mostly caused by Haemophilus influenza type B, or Heb. But thanks to the Heb vaccine, that's become much rarer in vaccinated children.
So who gets it now?
We still see it, but now it's often caused by other bacteria like strep species or Staph aureus. And critically, we see it in adults too, sometimes even caused by fungal infections like Candida in immunocompromised adults. But regardless of the cause or age, the underlying problem is the same: rapid, severe inflammation and swelling of the epiglottis and surrounding tissues.
The little flap that covers the windpipe when you swallow.
Right, and when it swells massively, it can completely block the airway opening. It's a true emergency.
What are the absolute must-know signs and symptoms, the things that should make alarm bells ring?
Think rapid onset develops over hours. Usually acute high fever, severe sore throat, often seeming much worse than the throat looks initially, and difficulty swallowing, which leads to the hallmark drooling because they can't manage their own saliva.
Okay, fever, severe pain, drooling. What else?
Their voice often changes, becoming muffled, sometimes described as a hot potato voice, like they're trying to talk with a hot potato in their mouth. If the airway narrowing is significant, you'll hear stridor, a high-pitched noise on breathing in. And they often adopt the tripod position, instinctively sitting up, leaning forward, neck extended, hands planted, trying to keep the airway as open as possible.
That tripod position sounds critical to recognize.
It is. It's a sign of significant respiratory distress.
How is it diagnosed? Do you look in the throat?
Okay, this is vital. In children especially, if you suspect epiglottitis based on those signs, you do not attempt to examine the throat with a tongue depressor or scope in an unsecured setting, like an office or ER room.
Why not? That seems counterintuitive for a sore throat.
Because manipulating that severely inflamed, swollen epiglottis can trigger complete laryngospasm, the airway slams shut. It can cause immediate, total airway obstruction. Diagnosis is primarily clinical suspicion. If the patient is stable enough and it won't delay definitive airway management, a lateral neck X-ray can be helpful.
What do you see in X-ray?
The classic finding is the thumb sign. The swollen epiglottis looks like a large thumbprint projecting into the airway where you'd normally see a thin structure. But again, imaging should never delay securing the airway if the patient is unstable.
Okay, so suspicion is high, patient looks sick. What is the absolute #1 priority?
Immediate airway stabilization, period. This usually means getting the patient to a controlled setting, typically the operating room, with anesthesia, an ENT, or emergency physician ready for intubation.
What if intubation is difficult or fails because the swelling is just too bad?
This is where you need a plan B ready before you even attempt intubation. If intubation fails after maybe 1 or 2 skilled attempts, or if the patient is crashing and severely hypoxemic, you don't keep trying to intubate from above. The next step must be a surgical airway.
Cricothyrotomy.
Yes. An immediate surgical cricothyrotomy, creating an opening through the cricothyroid membrane below the level of the obstruction. It bypasses the swollen epiglottis entirely and saves their life. Only after the airway is secured should you worry about starting IV antibiotics, typically broad coverage like ceftriaxone plus vancomycin initially.
Wow, okay, airway first, always. Let's move to 3.2. Some other pediatric airway issues, these ones often congenital. Laryngomalacia, you said this is the most common cause of stridor in babies.
Yes, by far. Laryngomalacia isn't an infection or swelling, it's a structural issue. The tissues above the vocal cords, the supraglottic structures like the epiglottis and arytenoid cartilages, are immature and floppy.
So what happens when they breathe?
When the infant breathes in, the negative pressure generated in the airway pulls these floppy tissues inwards, causing them to partially collapse over the airway opening. This generates the characteristic inspiratory stridor, a noisy sound on breathing in.
How do you recognize this is laryngomalacia and not something else?
The key differentiators are the timing and the effective position. The stridor usually appears in the first few weeks of life and often gets loudest around 4 to 8 months of age. And the absolute clinical nugget is the positional change. The stridor is typically worse when the baby is lying on their back, supine, or when they're upset or feeding, but it significantly improves when they're placed on their stomach, prone.
Why does prone help?
Gravity helps pull the floppy tissues forward, away from the airway opening.
Does it get better on its own?
Thankfully, yes, in most cases. As the baby grows, the laryngeal cartilages stiffen, and the condition usually resolves spontaneously by 12 to 18 months of age. Only severe cases might need surgical intervention.
Okay, another critical neonatal airway issue. Bilateral choanal atresia. What's going on here?
Choanal atresia is a congenital blockage of the back of the nasal passage where the nose connects to the throat. It can be bony or membranous. If it's bilateral, meaning both sides are blocked, it's an immediate problem at birth.
Why is it such an emergency?
Because newborn infants are obligate nose breathers. They haven't yet developed the reflex to reliably breathe through their mouths. So if both nasal passages are blocked, they can't breathe effectively when their mouth is closed.
So how does this present right after birth?
The classic clinical picture is a newborn who is pink and breathing okay when crying, but develops cyanosis, turns blue when quiet or attempting to feed.
Why does crying help?
Because when they cry, their mouth is open, creating an airway. When they close their mouth to feed or rest, the nasal obstruction prevents airflow and they become cyanotic. Failure to pass a suction catheter through the nose is also a major clue.
What's the immediate management?
You need to establish an oral airway immediately. This can sometimes be done by simply placing an oral airway device or even just modifying a pacifier or a nipple to keep the mouth open and the tongue down. This buys time until definitive surgical repair can be performed to open the choanae.
And you mentioned this can be linked to other issues.
Yes, choanal atresia, especially bilateral, can be associated with other congenital anomalies, sometimes as part of the VACTERL association, which stands for vertebral defects, anal atresia, cardiac defects, tracheoesophageal fistula, renal anomalies, and limb defects. So finding choanal atresia warrants a thorough look for these other potential problems.
That's a crucial connection. Okay, still in the neck, let's talk about differentiating common neck cysts based on location and movement. Thyroglossal duct cyst versus branchial cleft cyst.
Right, these are common congenital neck masses. The thyroglossal duct cyst, TGDC, is the key one to remember as being midline. It forms from remnants of the thyroglossal duct, which is the path the thyroid gland takes during embryonic development as it descends from the base of the tongue down to its normal position in the lower neck.
So it's usually somewhere between the tongue base and the thyroid.
Exactly, typically near the hyoid bone in the midline of the neck. And the absolute definitive diagnostic physical exam finding is its movement with swallowing or tongue protrusion.
Why does it move with the tongue?
Because the thyroglossal duct is embryologically attached to the base of the tongue. So when the tongue moves up and back during swallowing or sticking it out, the cyst gets pulled upwards too. Seeing that upward movement is virtually diagnostic of a TGDC.
And management.
Surgical removal is recommended because they can become infected. The specific operation is called the cyst trunk procedure, which involves removing the cyst, the tract all the way up to the base of the tongue, and the central portion of the hyoid bone to prevent recurrence.
Okay, midline, moves with tongue, thyroglossal duct cyst. Now contrast that with the branchial cleft cyst.
Branchial cleft cysts are different. They arise from remnants of the branchial arches, embryonic structures in the neck. The most common type, from the second branchial arch, typically presents as a lateral neck mass.
Lateral, meaning off to the side.
Yes, usually found along the anterior border of the sternocleidomastoid SCM muscle, somewhere between the angle of the jaw and the clavicle. It's typically smooth, soft, cystic, and fluctuant. Unlike the TGDC, it does not move with swallowing or tongue protrusion.
When do they usually appear?
They might be present from birth, but often don't become noticeable until childhood or young adulthood, frequently appearing or suddenly enlarging after an upper respiratory infection, likely due to inflammation of lymphoid tissue within the cyst wall. Management is also surgical excision.
Great distinction. Midline moves with tongue. TGDC. Lateral anterior to SCM equals branchial cleft cyst. Now, section 3.3, shifting to cancer red flags in the throat and voice box. Let's start with a tricky one. Referred overtalgia, ear pain, but the ear is normal.
This is such an important concept and potentially very dangerous if missed. Referred-otalgia is ear pain, where the source of the pain isn't actually in the ear itself. The ear exam looking at the canal and eardrum is completely normal.
So why does the patient feel pain in their ear?
It's due to shared nerve pathways. Several cranial nerves supply sensation to both the pharynx, throat, and larynx, voice box, and the ear. Primarily the glossopharyngeal nerve, CNIX, and the vagus nerve,
Okay.
CNX. So if there's an irritation, or more ominously, a tumor growing in the throat, particularly areas like the base of the tongue, the hypopharynx, lower throat, or the larynx, it can irritate branches of these nerves. The brain then misinterprets the pain signals as originating from the ear because those nerves also serve the ear.
Who should we be most suspicious in?
You absolutely must suspect an underlying head and neck squamous cell carcinoma, HNSCC, in an older patient, especially one with significant risk factors like a long history of smoking or heavy alcohol use, who presents with persistent unilateral ear pain and has a completely normal ear exam. Recent data also points to HPV as a major risk factor, especially for oropharyngeal cancers, even in younger non-smokers.
So normal ear exam plus risk factors plus persistent unilateral ear pain. It goes alarm bells.
Huge alarm bells. Don't just reassure them or give ear drops. The necessary next step is a thorough examination of the potential source areas. That means performing flexible laryngopharyngoscopy using a small camera passed through the nose to directly visualize the nasopharynx, oropharynx, hypopharynx, and larynx to look for a primary tumor.
Got it. What about other direct symptoms of cancer in that area, like laryngeal SCC?
For laryngeal squamous cell carcinoma, the voice box cancer, the cardinal symptom is persistent hoarseness lasting more than, say, 30 days, especially in someone with smoking or drinking history. Any persistent change in voice quality warrants visualization of the vocal cords.
What would you see on laryngoscopy?
You might see an irregular, bumpy, ulcerated, or fungating mass growing on one or both vocal cords, impairing their vibration and causing the hoarseness.
And oropharyngeal SCC, like in the tonsil.
For oropharyngeal SCC, often involving the tonsil or the base of the tongue, key signs are a persistent sore throat, often localized to one side, difficulty swallowing, dysphagia, or the presence of a non-healing ulcerated lesion in the tonsillar area. Another major red flag is finding a persistent neck mass, which often represents metastasis to a cervical lymph node, typically on the same side, ipsilateral.
You mentioned HPV earlier. How does that change the picture for oropharyngeal cancer?
It's changed dramatically. While smoking and alcohol are still major causes, particularly in older individuals, there's been a huge rise in HPV-associated oropharyngeal SCC, especially involving the tonsils and base of tongue. These tend to occur in younger patients, often without the traditional smoking-drinking risk factors.
Does the cause affect the outcome?
Interestingly, yes. Generally speaking, HPV-positive oropharyngeal cancers tend to have a significantly better prognosis in response to treatment compared to HPV-negative cancers, those typically caused by smoking alcohol. It highlights a different biology for these tumors.
Okay, entering our final section, section 4. Let's look at salivary glands first. 4.1. We need to differentiate painful versus painless swelling. Let's start with the painful one. Suppurative parotitis.
Right, this is an acute bacterial infection of the parotid gland, the large salivary gland located in front of and below the ear.
What leads to this infection?
The key risk factors involve situations that lead to salivary stasis, meaning reduced saliva flow. This is common in elderly patients, especially those who are postoperative, dehydrated, or have poor oral hygiene. When saliva flow slows down, bacteria from the mouth can travel backwards up the salivary duct, Stenson's duct, and infect the gland itself. Staph aureus is a common culprit.
How does it present clinically?
It presents acutely with firm, warm, erythematous red swelling over the parotid gland area. And the key differentiator is that it's usually exquisitely tender to touch. Patients might also have fever, chills, and sometimes purulent discharge can be expressed from the duct opening inside the cheek if you massage the gland.
Management.
Requires prompt treatment with antibiotics that cover typical oral flora, hydration to encourage saliva flow, warm compresses, and sometimes salagogues, like lemon drops or tart candies, to stimulate saliva production. If an abscess forms, drainage might be necessary.
Okay, that's the painful infected gland. Now what about painless enlargement? Sialadenosis.
Sialadenosis is quite different. It's a benign, non-inflammatory, non-neoplastic enlargement of the salivary glands, most commonly affecting the parotids bilaterally.
So both sides swell up, but it doesn't hurt.
Exactly. The key features are bilateral, generally symmetric, soft or rubbery, and painless swelling. It's not an infection.
What causes it then?
It's usually associated with an underlying systemic condition. Common causes include chronic alcohol use, malnutrition, like in eating disorders such as bulimia, diabetes mellitus, and certain metabolic or endocrine disorders. The gland enlargement is thought to be due to autonomic neuropathy affecting salivary secretion or abnormal accumulation of secretory granules within the gland cells.
So the management isn't antibiotics.
No, not at all. Management involves identifying and addressing the underlying systemic cause. For example, optimizing blood sugar control in a diabetic patient, addressing nutritional deficiencies, or managing alcohol dependence. The gland swelling itself usually improves if the underlying condition is treated.
When evaluating any parotid mass, though, even though most are benign, what's the single biggest red flag for malignancy?
The most ominous sign concerning for a malignant parotid neoplasm is involvement of the facial nerve, cranial nerve 7.
Why is that?
Because the facial nerve runs directly through the parotid gland, dividing it into superficial and deep lobes. Benign tumors usually grow slowly and push the nerve aside. Malignant tumors, however, are often invasive and can directly infiltrate or encase the nerve fibers.
So what would the patient experience?
They would present with facial weakness or paralysis, facial droop, on the same side as the parotid mass. Finding a parotid mass coupled with any degree of facial nerve dysfunction is highly suspicious for malignancy and warrants urgent investigation, usually starting with imaging and fine needle aspiration biopsy.
Okay, crucial nerve sign. Let's move to 4.2. Critical postoperative issues, specifically after thyroid surgery. What's the immediate emergency we have to watch for?
The most feared immediate complication after thyroid or parathyroid surgery is a rapidly expanding postoperative neck hematoma.
A bleed in the neck. Why is that so dangerous?
Because the neck is a relatively tight space, enclosed by fascial layers. If a blood vessel starts bleeding after the surgery is closed, the accumulating blood, hematoma, has nowhere to go except to compress surrounding structures, most critically, the trachea, windpipe.
Leading to airway obstruction.
Exactly. It can cause rapid airway compromise, leading to stridor or respiratory distress and potentially suffocation if not recognized and treated immediately. Signs include rapidly increasing neck swelling, neck tightness or pain, voice change, difficulty breathing, or stridor.
If you suspect this, what is the absolute mandatory protocol? Do you wait for a scan?
Absolutely not. Time is critical. You do not delay definitive management to get imaging like a CT scan. If there are signs of airway compromise or a rapidly expanding hematoma, the mandatory action is immediate wound exploration and hematoma evacuation, ideally right at the bedside.
Open the incision right there.
Yes. You need to immediately open the surgical staples or sutures, release the clot, and relieve the pressure on the airway. This can be life-saving, even before getting the patient back to the operating room for definitive control of the bleeding source. Airway comes first.
Okay, that's a vital emergency point.
Right.
Once the patient is recovered, how do we monitor for thyroid cancer recurrence? The markers seem to differ by type.
They do. For medullary thyroid cancer, MTC, which arises from the calcitonin-producing C cells, the primary tumor marker used for surveillance after surgery is serum calcitonin.
Calcitonin, is that the only one?
Calcitonin is the most sensitive and specific marker for MTC. CEA, carcinoembryonic antigen, can also be elevated and is often monitored alongside calcitonin, but calcitonin is key. Importantly, thyroglobulin is not useful for MTC surveillance as MTC cells don't produce it.
Okay, calcitonin, maybe CEA for medullary. What about the more common types, papillary and follicular thyroid cancers? These are called differentiated thyroid cancers.
Correct. For differentiated thyroid cancers, DTC, like papillary and follicular, the standard treatment usually involves total thyroidectomy, removing the whole gland, often followed by radioactive iodine, RAI, ablation, to destroy any remaining thyroid cells, normal or cancerous.
So the goal is no thyroid tissue left.
Exactly. Therefore, the main tumor marker for surveillance is serum thyroglobulin. Thyroglobulin is a protein made only by thyroid follicular cells, normal or cancerous. After total thyroidectomy and successful RAI ablation, the TEG level should be undetectable or very low.
So a rising TG level later on means?
A rising TG level strongly suggests cancer recurrence or persistence, as there shouldn't be any normal thyroid tissue left to produce it. We also measure TG antibodies, TGAb, as their presence can interfere with the TAG assay.
And there's a role for TSH suppression too.
Yes. Patients are typically kept on levothyroxine, thyroid hormone replacement, at doses high enough to suppress TSH, thyroid-stimulating hormone levels. TSH can act as a growth factor for DTC cells, so keeping TSH suppressed helps reduce the risk of stimulating any residual cancer cells to grow.
Okay, that makes sense. Last subsection, 4.3. Damage from lifestyle, treatments, and trauma. Let's start with something seemingly minor but annoying: CPAP-associated epistaxis, nosebleeds from CPAP machines.
Yeah, this is actually quite common for people using continuous positive airway pressure, CPAP, for sleep apnea. The machine constantly blows air into the nose, and if that air is cool and dry, it can really dry out the nasal lining, the mucosa.
Play into.
Dryness leads to crusting, irritation, and fragility of the small blood vessels, particularly on the anterior nasal septum, the caecil back plexus area where most nosebleeds originate. This results in mild, recurrent nosebleeds, epistaxis.
What's the fix? It sounds like managing the air is key.
Absolutely. The primary and most effective intervention is to add heated humidification to the CPAP setup. Delivering warm, moist air instead of cold, dry air prevents the excessive drying of the nasal mucosa.
Any other tips?
Using over-the-counter nasal saline sprays regularly can also help keep the mucosa moist. Some people find applying a nasal lubricating gel or ointment inside the nostrils at bedtime is beneficial too, but the heated humidifier is usually the game changer.
Okay. Now, a much more serious iatrogenic issue: bisphosphonate-related osteonecrosis of the jaw, ONJ. This affects bone healing.
Yes, ONJ is a significant potential complication primarily associated with bisphosphonate medications used for osteoporosis or cancer-related bone disease, and also some other anti-resorptive or anti-angiogenic drugs.
What actually is it?
It's defined as an area of exposed, necrotic, dead bone in the jaw, more often the mandible than the maxilla, that persists for more than 8 weeks, usually occurring after some form of dental trauma or procedure, most commonly a tooth extraction.
Why do bisphosphonates cause this?
Bisphosphonates work by inhibiting osteoclasts, the cells responsible for breaking down and remodeling bone. While this is great for strengthening bone overall, it severely impairs the bone's ability to heal after injury or surgery. The bone in the jaw has high turnover, so it's particularly susceptible. After a tooth extraction, the underlying bone socket can't remodel and heal properly, leading to a vascular necrosis. The bone tissue dies due to lack of blood supply and becomes exposed in the mouth.
How is it managed? It sounds difficult.
Management is very challenging. The focus is often on conservative measures, maintaining excellent oral hygiene, using antimicrobial mouth rinses like chlorhexidine, managing pain, and treating any secondary infections with antibiotics. Surgical debridement is sometimes necessary but can risk making the area of necrosis larger. Prevention is key, trying to complete necessary dental work before starting high-risk medications if possible.
A serious consideration for patients on those drugs. Lastly, let's talk about a classic sports injury result: auricular hematoma and the dreaded cauliflower ear.
Right. An auricular hematoma is a collection of blood that forms between the cartilage of the outer ear, the auricle, and the overlying skin and perichondrium, the connective tissue layer that supplies blood to the cartilage.
How does it happen?
It's typically caused by blunt trauma or shearing forces to the ear, common in contact sports like wrestling, boxing, or rugby. The trauma causes blood vessels in the perichondrium to rupture, and blood accumulates, lifting the perichondrium off the cartilage.
Why is that separation such a problem?
Because the ear cartilage gets its entire blood supply and nutrients from the overlying perichondrium. If a hematoma separates these two layers, the cartilage is starved of oxygen and nutrients. This leads to cartilage death, necrosis, and subsequent scarring and fibrosis.
And that results
in the classic cauliflower ear deformity, a thickened, bumpy, distorted appearance of the outer ear, which is permanent once it develops.
So how do you prevent cauliflower ear if someone gets an auricular hematoma?
The management must be immediate and urgent drainage of the hematoma. This usually involves making an incision in the skin and suctioning out the blood clot. Critically, after drainage, a pressure dressing must be applied to hold the skin and perichondrium firmly back down onto the cartilage, allowing blood supply to be restored and preventing the hematoma from reaccumulating. Antibiotics are also usually given to prevent infection. Prompt treatment is key to preventing the permanent deformity.
Wow. We've covered an immense amount of ground today, from the sinuses all the way down to the larynx and out to the ear. What really strikes me is how often diagnosis hinges on these very specific details: the timing of symptoms, a visual cue like granulation tissue or a thumb sign on X-ray, or how a mass moves.
Absolutely. That's really the essence of this deep dive, isn't it? Recognizing those critical differentiators. Knowing that severe ear pain plus granulation tissue in a diabetic isn't just swimmer's ear, it's likely necrotizing otitis externa needing IV drugs. Or that persistent hoarseness needs a scope, not just voice rest. Or that midline neck mass moving with the tongue points straight to a thyroglossal duct cyst.
It's about connecting those dots quickly and accurately.
Precisely. And seeing the bigger picture, too. How often do these seemingly localized ENT symptoms actually flag much larger systemic issues? We talked about diabetes and NOE, congenital syndromes like Vactorol linked to choanal atresia.
And the huge shift in head and neck cancer causes, with HPV becoming so prominent.
Right. That linkage between oropharyngeal cancer and HPV, especially in younger, non-smoking patients, is a profound epidemiological shift. It really changes how we need to think about risk.
Which brings us to that final provocative thought, doesn't it? If the traditional risk factors of smoking and drinking are no longer the only major drivers for a significant portion of these aggressive cancers,
Then how do we adapt? That's the question for you, the listener, to ponder. Given this rise in cancers driven by a common viral exposure, HPV, often in people without that classic at-risk history, what does this mean for public health? Should we be thinking about new screening approaches, different awareness campaigns? How do we effectively identify and manage these cancers earlier now that the risk profile has fundamentally changed for so many?